Hello friends, welcome back to Cortex YouTube channel. In this video, I will talk about subclinical hypothyroidism. What is it, how to diagnose it, and what are the causes of subclinical hypothyroidism, and when to treat and when not to treat. So these are the points which I am going to highlight in this video. And before proceeding, I would like to make a statement here. Not all elevated TSH is because of subclinical hypothyroidism. Remember this statement. So this statement helps you to tackle whenever there is cases of elevated TSH. So before proceeding to the width and depth of the topic, let me go through the clinical scenario here. A 36-year-old asymptomatic woman undergoes routine health screening. She has no complaints, normal menstrual history, and no weight change and no neck swelling. Her lab reveals TSH 6.8 milli international units per liter. Normal is 0.4 to 4, okay, and free T4 is normal here. So by looking at the just this report, some people will think it is subclinical hypothyroidism, which may be true. I am not saying it is not true, but we should not jump to diagnose subclinical hypothyroidism just by one TSH reading. That's what the point which I want to make here clear. So one TSH value, you can't make uh, diagnosis of SCH, that is subclinical hypothyroidism. So in this video, whenever I tell SCH or write SCH, it means subclinical hypothyroidism. So how to proceed when such case scenario comes in your routine OPD, that I will discuss later. We'll come to this case scenario again at the end. Now we'll discuss about the definition of the subclinical hypothyroidism. So definition goes like this. It's a persistent elevation of TSH in the setting of normal free T4 or T4 concentration. So every word is here important. See, it is persistent. It is not a single reading. Persistent, okay, that means it is 12 weeks or longer. So if elevated TSH persists for 12 weeks or longer, 12 weeks means your simple 3 months. So 12 weeks or longer in the setting of normal free T4 or total T4. If it is so, then we can diagnose subclinical hypothyroidism. Remember, it is persistent elevation of TSH. Okay. So in the beginning, I made one statement here. Not all elevated TSH is because of subclinical hypothyroidism. So you should know the causes of elevation or elevated TSH levels. So what are the causes of elevated TSH? The causes of elevated TSH or raised TSH includes the most common being nocturnal measurement of TFT. Now physiologically, TSH value will be more in the night. So if you measure TSH levels in the night, obviously it will show more. And because of aging, physiologically increasing aging is associated with raised TSH. Third one is recovery phase of non-thyroidal illness. Patient may be in ICU for a different reason, and if you check TSH, it will be elevated obviously. Then because of severe obesity and thyroid hormone resistance, and never forget about drugs. So drugs also can cause elevated TSH. So namely your amiodarone, lithium. So these are all the drugs which causes elevated TSH. So whenever you get a TSH elevation, one reading, you start looking for these causes. If the patient is having these causes, then you treat accordingly, or if the patient is not having these causes, you repeat the TSH after 3 months only to diagnose subclinical hypothyroidism. Okay. So this is about causes of TSH elevation. So how to diagnose? How to diagnose? How to diagnose SH? So how to diagnose? Diagnosis of SH. So SH diagnosis is nothing. It's just simple. So TSH has to be elevated. One thing is, it has to be elevated TSH with normal T4 or free T4 on two occasions, on two different occasions, 12 weeks apart. So all the words in this sentence is very important. See, TSH has to be elevated obviously. Elevated means how much? More than upper limit of normal. Okay. and T4 has to be normal. See, T4 has to be normal free, either it is total T4 or free T4. If it is also decreased, then it is overt hypothyroidism. But T4 is normal, TSH is elevated, that means it is subclinical hypothyroidism, provided two different occasions 12 weeks apart TSH values are present. So let me repeat once again because it's worth repeating. Elevated TSH and normal T4 on two different occasions 12 weeks apart. So if it is so, that means if a patient comes to you OPD showing one reading of TSH 7, and you ask the patient to repeat the TSH after 3 months, if it is elevated in after 3 months also with the normal T4, then you can make a diagnosis of subclinical hypothyroidism. So what are the causes of this subclinical hypothyroidism? So causes of subclinical hypothyroidism includes chronic autoimmune thyroiditis, okay, or subacute thyroiditis, then postprandial thyroiditis, then iatrogenic like subtotal thyroidectomy or radioiodine therapy or external radiation for other malignancies in the head and neck region, and infiltrations like sarcoidosis, amyloidosis. So these are the some causes for clinical hypothyroidism. Don't again forget drugs. So I already told drugs: amiodarone and lithium. So and your sulfonamides, sulfonylureas, iodine, all these causes subclinical hypothyroidism. So and obviously don't forget this is inadequate replacement of overt hypothyroidism. Inadequate replacement of overt hypothyroidism. If you don't correct it properly or inadequate dose if you use, it will cause subclinical hypothyroidism picture. Okay, so these are the causes of subclinical hypothyroidism. So why I have to be concerned about this subclinical hypothyroidism, or why I have to treat this subclinical hypothyroidism? Because it is associated with the high risk of heart failure and pregnancy loss, depression, bipolar disorders, and cognitive impairment, cognitive dysfunction, and non-alcoholic fatty liver disease. So these are the complications of subclinical hypothyroidism if you don't treat it. Okay, and it's also associated with annual, because once a patient, if you diagnose subclinical hypothyroidism, the risk of annual progression or annual risk of progression to overt hypothyroidism is around 3 to 18%. Okay, 3 to 18%, that's a quite a lot. And more in which individual it's more in elderly female with positive anti-thyroid antibodies, and those who have received radioiodine therapy for Graves disease or external radiation treatment in head and neck region, and chronic lithium therapy. So these are the individuals at risk of progression to overt hypothyroidism. Okay, that's why you have to find out and treat these cases. So when I have to treat, that's a question. When I have to treat, whenever subclinical hypothyroidism patient is there with following any one of this, you can treat the patient, okay, by levothyroxine LT4. So subclinical hypothyroidism patient having goiter, you can treat. Antithyroid positive antithyroid antibodies, you can treat. If history of smoking and dyslipidemia is there, you have to treat. And history of depression, bipolar disorder, cognitive dysfunction, and pregnancy or intention to get pregnancy, you have to treat. And if the patient is young, you have to treat. And TSH value more than 8 in 2 readings, you have to treat. Or progressive elevation of TSH, like last time it was 3 months back it was 6, now it is 7.5 or 8, you have to treat that condition because it is progressive elevation of TSH. Or both the readings more than 8, like 8.5, 8.5, 8.5, 9, so you have to treat that conditions. So these are the conditions, or these are the factors favoring LT4 treatment or levothyroxine treatment in cases of subclinical hypothyroidism. So what is the dose of LT4? You usually Dose depends on the whether the patient is symptomatic or not, and patient is the age of the patient. So, and goal also depends upon the age of the patient. So we usually start with low dose, that is 25 to 50 micrograms OD before breakfast every day. Okay, so this is the usual dose with what we start treatment of subclinical hypothyroidism, and we have to always titrate this, okay, this dose depending upon the follow-up TSH every 6 to 8 weeks. Okay, then what is the goal or target? When if the individual is less than 65 years, my target is 0.5 to 2.5 milli international unit per liter. If the patient is more than 65 years, my target is changes to 3 to 5 milli international unit per liter, because of a high risk of cardiovascular events or like arrhythmias. So this is about the LT4 or levothyroxine dose and the target. So how we are going to achieve this, or how we are going to monitor this, we will now look at this. So you go for you so subclinical hypothyroidism, you started LT4. Now what to do, you repeat the TSH, repeat TSH at 8 to 12 weeks, 2 to 3 months. Now it can be absolutely normal, or it can be in the range of target range. So you just continue the treatment and repeat TSH 6 monthly and then annually. This is how you treat. Okay, when it is TSH is in the normal means target range, target is achieved, so you go for continuous same treatment and repeat TSH at 6 months and then annually. Okay, if TSH is not in normal range, then what to do? If it is not, target is not achieved, or target is, the TSH is too low, then you have to decrease a T4 dose. So decrease T4 dose by how much? 12.5 to 25 microgram. So this is how you have to decrease. If TSH is too high, that means the dose you are giving is inadequate, so you increase the dose, increase the LT4 dose by 12.5 to 25 microgram. So this is how you are going to monitor the case of subclinical hypothyroidism. So once you diagnose subclinical hypothyroidism and there are indications for levothyroxine therapy, you start with levothyroxine therapy. After 8 to 12 weeks or 2 to 3 months, you repeat once again TSH. If target is achieved, repeat it after 6 months, then annually. If target is not achieved and TSH is too low, you have to decrease T4 levels by how much? 12.5 to 25 microgram. So this is the titration dose, that is 12.5. Either we have to increase the dose by 12.5 or decrease the dose by 12.5 or 25 micrograms. So one more case scenario is if the at follow-up TSH level is higher, it's not in well within the target range, still high. So that means what? The dose that you are giving is inadequate. So increase the dose of LT4 by how much? Again same, it is 12.5 to 25 micrograms. So this is how you initiate the dose. I have discussed the indications for LT4 in subclinical hypothyroidism and dose and the target and how to monitor. So this is about subclinical hypothyroidism. So in nutshell, if you want me to summarize, let's suppose there is TSH is elevated and normal T4 on two different occasions with 12 weeks apart. So that is exactly the definition of subclinical hypothyroidism. So you diagnose subclinical hypothyroidism and there are indications for LT4, or let's suppose TSH level you have to say. TSH level more than 10, you directly start with LT4. If TSH level is more than upper limit of normal and less than 10, so between upper limit of normal and less than 10, so that time what you have to go for, you just check the patient's age more than 65, age less than 65. more than 65, just observe, and patient is asymptomatic or without symptoms, just observe the patient and repeat TSH at 6 month and then yearly, then annually. If the patient is less than 65 years, what to do? So you aren't symptomatic or those indications for LT4 are present, so that time you have to go for LT4 therapy. LT4 therapy, what is the dose? 25 microgram OD before breakfast, then titrate LT4 dose, okay, after repeating the TSH, titrate accordingly. Okay, so this is about the identification, the causes, and what are the indications of LT4 in the management of subclinical hypothyroidism, and how to monitor, and the flow chart. So hope you find this video useful, and if so, please share among your friends, colleagues, and juniors. Thank you, thank you, thank you so much.